Thank you, Dr. Napon, for the kind introduction. A very good morning, everyone. And thank you to the organizing committee, HIV-NAT, Thai Red Cross, as well as the Faculty of Medicine at Chula for the kind invitation and the warm welcome in Bangkok. It's truly an honor to be here. My topic today is something very close to my heart: cervical cancer elimination in the Asia-Pacific. Cervical cancer elimination is now firmly on the global health agenda. But whether elimination is achieved varies widely, shaped by differences in access, health system design, and how prevention services reach women. So today, I'll focus on cervical cancer elimination in the Asia-Pacific region, with particular attention to women living with HIV. I have no conflicts of interest to declare for this presentation. Here's how I'll structure my talk today. I'll begin by briefly setting the scene for cervical cancer in the Asia-Pacific and why this region matters for global elimination efforts. I'll then focus on women living with HIV, where the risk is amplified and where prevention strategies require particular attention. And then from there, I'll highlight what is already working across the region, including selected regional examples, before turning to the gaps that continue to limit our progress. I'll conclude by focusing on practical, implementation-oriented strategies for how we move forward. So why does cervical cancer elimination matter? It matters first and foremost because cervical cancer affects women in the prime of their lives. These are women who are mothers, caregivers, partners, and when a woman is affected, the impact extends far beyond the individual, shaping family life and everyday stability. What makes this particularly striking is that cervical cancer is also one of the few cancers we have the tools to prevent and control, through effective HPV vaccination, screening, and timely treatment. Prevention is not only life-saving, it is far more cost-effective than managing advanced disease. And yet, despite these advances, despite science actually catching up, cervical cancer remains a significant cause of illness and death for women across the region. To understand the scale of this, let us look at the global burden and where the Asia-Pacific sits within it. This map shows age-standardized incidence in blue and mortality in red from cervical cancer globally. The darker the color, the higher the incidence and the higher the mortality. And what is immediately apparent is that the highest burden of disease and death is concentrated in low and middle income regions. And the Asia-Pacific accounts for more than half of global cervical cancer deaths. So while cervical cancer is a global disease, its impact is very clearly not evenly distributed. And when we zoom in into the Asia-Pacific, the inequities become even more striking. You can see countries like Australia, where incidence and mortality are low, sitting alongside neighboring countries where the burden remains high. And this is not because the biology of HPV is different. It's not because women in these countries value their health any less. It is because of access to vaccination, screening, early diagnosis, and treatment is very different. And this regional contrast is exactly why the Asia-Pacific requires focused attention in the cervical cancer elimination agenda. So what do we mean when we say elimination? The World Health Organization defines cervical cancer elimination as reducing incidence to fewer than 4 cases per 100,000 women. And to achieve this, the WHO has set the 90-70-90 targets for 2030, which means 90% of girls should be fully vaccinated against HPV by age 15, 70% of women should be screened with a high-performance test by age 35 and again at 45, and 90% of women with pre-cancer and invasive cancer receiving appropriate treatment. These are ambitious targets, but they are grounded in strong evidence and modeling. So how is the Asia-Pacific performing against these targets? Well, the picture is mixed. There are countries in the region that are on track or making very strong progress, including Australia, Bhutan, Brunei, Singapore, Malaysia, here in Thailand, and more recently Vietnam. driven by high HPV vaccination and coverage, national screening programs, and improved treatment access. Australia, in particular, is on track to become one of the first countries globally to achieve elimination by 2035, and Bhutan has already met the interim 90-70-90 milestones, which is a remarkable achievement for a low to middle income country. At the same time, many countries in the region are facing challenges. In large, highly populated countries such as India, China, and Indonesia, the sheer scale of the eligible population makes nationwide implementation a major challenge, even as new strategies and policies are introduced. In several Pacific Island nations, incidence and mortality remain among the highest globally, with limited access to screening and treatment services. We also see country-specific setbacks, such as in Japan, following a prolonged suspension of proactive HPV vaccine recommendations, and in the Philippines, where mortality has risen despite some improvements in screening. So while there is genuine progress in parts of the region, progress is uneven and far from sufficient. If no additional action is taken now, new cervical cancer diagnoses in the Asia-Pacific are projected to rise by almost 19% in less than 5 years, with deaths increasing by nearly 25%. Now, everything that I've shown you so far, the targets, the progress, the incidence, and mortality, is all based on population-level data. And population averages have a way of hiding the very groups who are at the highest risk. And what the numbers don't show are women living with HIV and marginalized women, including those in remote communities and migrant populations. And as a result, although national progress can look reassuring, high-risk groups remain invisible. And one of the most important of these groups are women living with HIV. There are 2.4 million women with HIV in our region, and when we look specifically at them, the risk picture changes dramatically. Globally, women with HIV are around 6 times more likely to develop cervical cancer compared to women without HIV. This is driven by a higher prevalence and persistence of the high-risk human papillomavirus and a greater likelihood of progression to pre-cancer and cancer, with higher recurrence even after treatment. Because of this, WHO has recognized women with HIV as a priority group, recommending earlier and more frequent HPV-based screening starting from age 25 and repeating every 3 to 5 years. Globally, we do have strong data. In Africa, cervical cancer accounts for 40 to 50% of all HIV-attributable cancers. But in the Asia-Pacific, we still lack disaggregated HIV-specific surveillance data, so we cannot accurately quantify the true incidence and mortality in women with HIV in our region. From studies across Africa, Europe, and the Americas, we know that high-risk HPV prevalence in women with HIV ranges from about 30 to 60%. In Asia-Pacific, however, most of what we have are small single-country studies, and we don't have regional pooled estimates for women with HIV. We also know globally that genotype distributions are diverse, but in our region, multi-country data are limited, and ethnic and regional variation is still poorly characterized. And this has real implications for both screening and vaccination strategies. And while HPV vaccines are safe and immunogenic in women with HIV, we still have no long-term effectiveness or durability data from Asia-Pacific populations. So there's quite a bit of knowledge gap for women with HIV in our region. But that does not mean the Asia-Pacific is standing still. There has been important work that has been emerging across the region, especially in epidemiology, screening delivery, service integration, and vaccination strategies. Let's start with epidemiology, because there are some important signals emerging from the region. From Bali in Indonesia, a recent study in women with HIV found that 24% were HPV DNA positive, with HPV 18 being the most prevalent genotype, and about 11% had abnormal cytology. In Thailand, a larger cohort of women with well-controlled HIV on antiretroviral therapy showed the high-risk HPV prevalence of 19%, with abnormal cytology of CAN2 and higher lesions in 3%. And the common genotypes included HPV 52, 39, 51, 16, and 18. Now, there are a few important points here. These are not women with advanced disease. Their CD4 counts are very reasonably preserved. And yet, the HPV burden and pre-cancer risk remained substantial. Secondly, the patterns are already differing across countries, both in prevalence and genotype distribution. Together, they highlight why we urgently need region-specific, HIV-specific epidemiology as we work towards cervical cancer elimination. So with that epidemiology in mind, the next question is, how are we screening our women with HIV? But before I go into screening strategies, I thought I'd just briefly align us all on the main screening tools. We have cytology right on top, whether it's the conventional pap smear or liquid-based, which is able to detect abnormal cervical cells. But its sensitivity for high-grade disease is only around 50 to 60%, and it performs less well in women with HIV. HPV DNA testing, in contrast, detects the virus itself and has high sensitivity to do so, above 90%. But importantly, it doesn't require a speculum and can be done by self-sampling, and this greatly improves acceptability. We have VIA, which is visual inspection, which is a low-cost option and used in some settings, but it is operator-dependent and less specific. And colposcopy is a diagnostic tool and not a screening one. So when we talk about optimal screening for women with HIV, HPV-based testing offers the best balance of sensitivity and acceptability. And based on this, the WHO recommends primary HPV DNA testing as the first-line screening tool, including for women with HIV. And screening strategies has also been evaluated in this region. A Thai study comparing cytology alone, HPV testing alone, or co-testing, so doing both together, and reflex strategies, meaning either you do a HPV test first and then you do a cytology, or vice versa. They found that the HPV-based approach improved detection of high-grade disease, although with trade-offs in colposcopy burden and resource use. So the direction is clear. HPV-based screening is the way to go. And so the next question is, how do we actually get our women with HIV to be screened in a timely manner in real-world settings? Well, first, we need to understand where the gaps actually are. In busy HIV clinics, there are competing priorities. Cervical screening often sits outside routine workflows, and referral pathways can be fragmented. In our own setting, we also found that there was limited awareness and confidence among HIV care providers around HPV risk and screening pathways. And then from the patient perspective, fear, stigma, discomfort, and low perceived risk remain major barriers. And so it's multiple layers of challenges across the system, the providers, as well as our patients. And so it was in response to all of these gaps that we at University Malaya Medical Center, where I work, developed an integrated model for cervical cancer screening within HIV care. And I'd just like to briefly share our experience. We started in late 2021 with a retrospective chart review, and we found that out of 170 women eligible at the time, only 12, which was 9.5%, had ever had HPV testing. And so that immediately obviously told us we had a problem. And so in 2022, it was our implementation phase. For the first 6 months, we just focused on clinic readiness. We made sure the self-sampling kits were available in the clinic. We put up instruction posters. We oriented our staff. We did knowledge like KAP questionnaires. We even introduced a small education bundle for both the providers and the patients. And then we measured 2 outcomes, which was cervical cancer screening engagement, so any conversation about cervical cancer screening in light blue, and actual HPV uptake in the dark blue bars. And you can see that we were barely moving. And so we asked our clinicians what was getting in the way. And the most common answer was a very honest, I forgot. And so at that point, we just added sticker reminders on patient cards. And you can see that it greatly improved engagement as well as uptake, although uptake lagged behind engagement. At this point, we added an implementation team member in the clinic to support active promotion. So she would go and remind the clinicians, HPV screening, HPV screening. And we also realized that cost was a major barrier, so we partnered with Rose Foundation to subsidize HPV testing for women with lower income. And what we did then from 2023 onwards is we deliberately stepped back from active promotion and we moved into post-implementation monitoring. So what we did was we kept the trained staff on site, just there, the reminder stickers and the subsidized tests in place, and we observed what happened and just measured uptake. And what you can see here is that uptake sustained across 2023, dipped a little bit in 2024, and picked up again in 2025, which is very reassuring because the service continued and continues to function in a real busy HIV clinic. But what I really want to share is that across the 4 years, there were 180 women who attended clinic. And of those, 155 or 86% were eligible for testing. And 69% actually underwent HPV testing. So this means we are now just shy of WHO's 70% screening target, but for a clinic that started at under 10%, this is a major shift and something that we are quite proud of. But importantly, 21% of women tested positive for high-risk HPV, which is similar, somewhat in between what was found in the Thai cohort and the Bali cohort, so somewhere in between. Almost all of our women were linked to follow-up care, and the only woman who wasn't sadly passed away from disseminated TB before we could do any further investigations for her. So why is our linkage to care quite good, 95%? And I just thought I'd share our linkage to care pathway. So we actually have a system-led pathway where our microbiology lab flags every HPV positive test to the colposcopy team through a secured shared platform, and the colposcopy team actively schedules the patient for review. But equally important is the relationship-driven pathway, where the ID team also traces the results and contacts the woman directly. And usually, the person who contacts the woman is someone she already knows and trusts. It is the same person who counseled her for the HPV test in the first place. And the thing is with women with HIV, there are many layers of stigma around HIV, around HPV, around sexual health. And having that familiar face, that clear communication, that active navigation reduces fear, it reduces dropout rates, and it keeps them engaged. And we believe that it is this combination of system plus relationship that explains the high linkage to care. This experience has taught us that integration works. And when screening is built into routine HIV care, women do take it up. But you need good communication, collaboration across teams, and active follow-up. There are still challenges to ensure sustained engagement from healthcare providers, and financing remains a real issue when screening needs to be repeated every few years. But moving forward, we are now expanding our work to a larger Ministry of Health hospital, and then we hope to expand this model and build a more sustainable pathway for women with HIV. I will now move on to vaccination. WHO recommends routine HPV vaccination for girls aged 9 to 14 and for immunocompromised individuals, including women with HIV. A 3-dose schedule is recommended. Catch-up vaccination is really important for those who haven't received it, and this is highly relevant for our women because many of whom were never vaccinated as girls and remain at lifelong risk. So this is the global guidance, and we've made some very encouraging progress across the region. First, we have very strong school-based programs and established school-based programs like in Malaysia, and more recently in 2023 started in Indonesia. Second, the inclusion of national immunization schedules, though with variable implementation due to issues with supply and logistics. There are also very innovative delivery models, including the paid forward strategies that has been published in China, and also integration into HIV platforms. So the foundations for HPV vaccinations are already in place. What we need now is intentional, coordinated scale. So we have made great progress, but we are still not where we need to be. And why is that? When you analyze it across countries, it consistently comes down to 4 gaps. The first is systems. Cervical cancer prevention often sits outside of routine workflows or HIV workflows, and referral pathways are often fragmented, and in busy clinics, it just simply competes with everything else. The second is financing. Whether it is the cost of a HPV test, the cost of the vaccine, the cost of colposcopy services, sustainable funding remains a major constraint in many settings. The third is data. We still have limited HIV-specific, region-specific epidemiology and outcomes data, which makes it very difficult to design targeted evidence-based programs for women with HIV. And the fourth is equity. Women who are already marginalized by geography, socioeconomic status, stigma, or even HIV, they're often the least likely to access screening and prevention services. So how do we move forward to eliminate cervical cancer in the Asia Pacific? We act now and we act together. For me, the path forward can be summarized in 6 simple priorities. The first is access. We need to integrate cervical screening and HPV vaccination services into services that women are already attending, whether it is primary care, reproductive health services, HIV services, instead of expecting women to navigate multiple disconnected systems. The second is coverage. We have to deliberately reach women who are usually missed. And these are the migrant women, the rural communities, are women with HIV. Elimination will only happen if it is inclusive. The third is testing. We need to scale up HPV DNA testing and self-collection. These are high-performance tools that work really well in real-world settings and reduce barriers to screening. The fourth is to normalize. Cervical cancer prevention should be routine in all care, diabetes care, HIV care, not an optional add-on, not a special referral, but part of standard practice. Normalizing screening also helps to reduce stigma around HPV, around sexual health, and around HIV, and it keeps women engaged. The fifth is to own the data. We need regional data platforms and disaggregated reporting so that women with HIV are visible in our statistics and our planning. And finally, we need to work together. No single center, no single country, and no single program will eliminate cervical cancer alone. It has to be regional, it has to be collaborative, and it has to be intentional. And I truly believe that the Asia Pacific can be the first region to eliminate cervical cancer in women living with HIV. And perhaps it is especially fitting that we are having this conversation in January, which is Cervical Cancer Awareness Month. Elimination is not a future concept. It is a present responsibility. So together, let's act now to eliminate cervical cancer in the Asia Pacific, including for women living with HIV. It truly takes a village, and I'm grateful to so many people. These are my acknowledgements. Thank you.